for the price they sell it to other people for, but that a part of that will be a subsidy and the rest will be paid for by the individual who gets the insurance. Now, what the Congress in the House and in the Senate has asked for is that people pay 3% to 12%, depending on their income, by themselves, and the rest will be subsidized by the government. So by raising the amount that they are themselves supposed to spend out of their own income, you're going to exclude a lot of people. So that's the higher you make the requirement for the percentage of their income that they are to pay for their insurance, the more difficult it is for them to buy the insurance. So we'll find many people who simply don't buy the insurance because of that. That's already happening in Massachusetts, has been happening for a number of years, since that plan was adopted a couple of years ago. And in regard to the another aspect of the corporate influence in Washington has to do with the ability of the nation to afford what it's going to cost to have this kind of subsidized insurance. The full potential for a public plan in the bill has been whittled away so that the public plan is going to be weakened to a considerable extent. The public plan, as most of you know, is supposed to be something that people can get that is run by the government, and the insurance premiums would be paid to the government. So what is happening to the public plan is that the extent of eligibility for getting the public plan has been reduced considerably by the insurance industry, who want to claim that it would be too great a competition for them to have to deal with a plan that would undersell them. So now, in order to be eligible for the plan, you have to be either someone who has no insurance, or you have to be someone who is an employee of a firm that doesn't give insurance. But you could possibly have insurance on the side, but if you have that insurance, you could change it in for the public plan. Now, the effect of this on the public plan is to reduce the number of people who are eligible to around 10 million people. And that's 10 million out of about 170 million people who are insured by employers. And you toss in a few more, and you have people who have individual insurance. So it's a very small number of the people who are going to be eligible for that public plan. So these are some of the things that this corporatist democracy of ours has limited our ability to have a healthcare plan that's going to live up to its hopes. All right. Now, let me go on to another aspect of the healthcare situation now. One of the things that people have been talking about a lot recently is that countries like Switzerland have done fairly well in terms of insurance for people by having private insurers. And there was a big article in the New York Times several weeks ago saying Switzerland is great. We can do what we can solve all of our problems with private insurance like they have. One thing they didn't point out in that article was that in Switzerland, the private insurance is not for-profit insurance. So in the U.S. situation, we think of private mainly as being for-profit. And of course, there was a time, for example, when you had the Blue Cross Blue Shield insurance, when it was not for profit. But the not-for-profits weren't able to raise enough capital, and the big insurance companies came in and began to gobble them up. And we have a situation which is dominantly a for-profit insurance system now. Now, so what's so bad about the profit aspect of the health insurers that people mostly rely on in the U.S. unless they have Medicaid or Medicare? This is, I think, a really crucial point that affects how well any plan can work if it's done with for-profit insurers. And consider the following situation. We've got an insurance company over here. We've got providers over here. We have doctors, we have hospitals, we have technical equipment companies. The insurer would love to be able to get more money from the premiums that they charge. They could do this in a variety of ways. They could get more people to sign up membership cards. They could do other things. They could say, well, we're just going to raise premiums. If we raise the cost of getting a membership, that will raise our aggregate premiums as well. And we'll have more profit to deal with. And most of the insurance companies invest their premiums, since they all aren't used up right away. Most of the insurance companies invest their premiums in, for example, WellPoint in Indiana, which is the largest insurer in terms of membership. They have invested their premiums in companies like Fannie Mae. So they buy these mortgage derivatives from Fannie Mae, and then their annual report for last year showed that they lost $1 billion on their investments. Now, they would love to have bigger and bigger aggregate premiums to invest in things like Fannie Mae, which in good times would yield them income. Now, on the other side, we've got the providers. And the providers are saying, we would like more income too. If I'm a hospital director, I would say, I could probably get a bigger salary if this was a bigger hospital. Maybe we should raise our rates. The doctors will say the same thing. So you see, there is a coincidence of interest between the insurance companies and the providers in raising premiums. If the insurance company looks at the providers and says, those guys are raising their rates and their doctor's fees,